home care physicians and nurse practitioners and other people in the field, I feel like these people are great. These people are like angels. Like, I really want to work with these people. Because if we are a provider, we are the healthy, we're the strong, we should go to the weak, to the sick, right? That's the way compassionate care should be. We do health policy, health management, health services research. It could be very clinical. Recently, I was writing a paper with Paul on pharmacist review of the medications of the home care patients, right? So that's the kind of clinical. And I'm also trying to work on other clinical stuff like the mobile ultrasound, the handheld ultrasound in home care practice. So I'm working with a company trying to get to do some kind of comparative studies. So that's kind of clinical. Then we also have healthcare services research. We try to look at the supply and demand of home care medicine in the country, the workforce, demand and the utilizations. Do we have, do our older frail patients have received home-based medical care? Are there disparities? And are there cost issue? And does home care medicine save money for patients, family, for the payers? And we can also work on other policy-related papers like independent at home, or the new payment model started by the CMS. There are probably two types of research projects. For academic research, it's all about if it's novel, right? First of all, you want to answer this question: is it novel? If it is not novel, it will be hard to get published. Like if someone have written about something like over and over, and you don't have a chance to get published in a good journal. So that's for academic research. We have to judge about novelty first. And then we will think about, well, do we have the data? Do we have the manpower to do the analysis? Okay, that's for academic research. And for some of the HCCI research projects, it's about, is it useful or is it practical? Okay, it's not about if we can publish somewhere like what we did for Florida, what we're doing for Chicago. It's not really about getting published in an academic journal. It's really about, is it useful? Is it helpful for the people we want to serve? As clients or patients, practices. If it is useful, they're helpful, then the next question is, do we have the data? Okay, and if we have existing data, that's great. If we don't have existing data, and can we collect the data, or is it time consuming? And do we need to spend a lot of money on data collection? And then if we think it's feasible, in terms of data access, it's feasible, then we're talking about the manpower to do the analysis. So we can use both secondary data and then primary, well, I should say primary and secondary. But actually, we for researchers, we always try to start with secondary data because it saves time, saves money, right? If there are existing data, we call them secondary data, okay? And so at HCCI, we have in-house secondary data from Medicare provider payments data, but we also use other data from other sources. For these two, this CMS, but we have population data from the Census Bureau. I can go on, but these are the major secondary data we're going to use. But for some clients or partners, if we need to collect some primary data. I think there are lots of primary data we can do, like quality data, benchmarking, practice information, and also patient report outcomes, caregiver report outcomes, EMR data. And we can do some comprehensive evaluation of certain home care programs. The secondary data or the existing data, it doesn't matter if it was first collected for research or not for research. Mm-hmm. Like the Medicare data, it's not for research, right? It's for payments, for billing, okay? But it's already there, and so that's secondary. Or there are other data collected by the federal government for research. There's National Health Interview Survey. There are other kinds of research data, but if somebody else collected that, that's called secondary data. And for primary data, we need to go and design a study and collect that data. And most often, it will be for research purpose, but sometimes it's different. Like if we try to get data from EMR, we're not going to get everything from the EMR. We might do some kind of medical record review, right? And to get that kind of information we need, it's kind of still considered a primary data. So it's much more expensive to collect your own data, as you know, like in the United States. If you want to do a survey, then it's very expensive. If you want to do an intervention and collect primary data, it's very expensive. So if you look at the webpage of the research webpage, it's mostly the two types of data or research project categorized by secondary data and primary data. I think it's mostly about using secondary data. And then the more expensive ones are related to primary data collection and analysis. I have a team that's good at data, analytics, infographics, visualization. We can do the full spectrum. I think for small practice, I don't think they have the resource to do. That's why we offer some low price tag service items. Like if you want to see the demands or needs in their region, if you want to see who are providing home-based primary care in the region, or they want us to help plan their practice, like which zip codes they want to cover, right? Because we have the data of demography information. Probably have some other small research questions they want to answer, and we can help them too. I think it could be part of the service we can offer in our consulting business. If they have some kind of questions and they think they have the data, but they don't have any analysts, right? So we can help them too. If they can ask us certain questions, we can help them. And some of the questions maybe it doesn't involve data analysis. Then maybe they just need our literature review, right? If they want to use that to talk to their local partners, they have that on our website. Why home-based primary care is effective and how it is effective and compared to other models. They are not specialized in home care medicine, many of them, or many of them, their analysts are not trained as researchers. So it's a little different. If you invest like $1 million in a comprehensive evaluation, you will need a very good evaluator, and you probably want to publish that. And most of these companies, they don't have the capacity to do academic research. Okay, so this is kind of both, combining being practical but also novel. So it's pretty hard to do. They're pretty good with data mining and answer questions for their administration leadership, but not towards the the academic or the policy side. That's a very good question. I came to Richmond in 2013, and I got to meet Peter Bowling, one of the founding fathers of modern home care medicine at VCU Geriatrics. We talked maybe for 5 minutes, and then I feel that's the model I was looking for, right? I really loved this holistic model of patient care. And I feel like going to patients, it's kind of going back to the old days of medicine. Physician doctors go to patients, and you treat your patient as a whole person. You see their environment and their social relationships, and then their clinical problems. So it's a holistic model, and I started to work on small questions. The first question is about how many people are doing that in the United States. So I was like pretty naive about a lot of things. I just emailed Bruce Leff and Christine Ritchie. I don't know them actually. I just emailed them like, hey, I actually did some data analysis, and do you want to take a look and co-author this? So he said, yeah, this is very interesting study, and we developed that paper into the first health affairs article. And I think Tom know me from that paper, or most people in home care medicine know me from that paper. And then I got to meet more home care physicians. And nurse practitioners and other people in the field. I feel like these people are great. These people are like angels. Like, I really want to work with these people. Because I think healthcare providers should go to patients and take care of patients. And sometimes I cite the scripture from Matthew, like about, I don't know if any of you remember or know that, it's about the goats and the sheep, and the sheep, they say like somebody is sick or is not well, then you go to them. Because if we are a provider, we are the healthy, we're the strong, we should go to the weak, to the sick, right? It should be that way. For the very old and the sick, it's just not right to me, but you should get them to you, and let them wait. So it doesn't sound right to me. So that's the way compassionate care should be.